So thank you again for the kind invitation, and always a pleasure to be.
Thushan dropped off. Side on the antimicrobial dressing.
No. Okay. Yeah, something happened. Yeah, Thushan.
Yeah, he's back. Well,
Right. Sorry. I hope I'm back again on.
Yes, yes, yes.
Right. And I hope my screen is visible.
Not yet, Thushan.
Can you spotlight my other? I have another
Yes.
laptop. Would you be able to spotlight that rather than this?
Where is that? I can see you.
Let me come in there. I must have lost that. Hold on.
Yes.
Won't have my just give me a small second.
Sure, sure. No worries. Yeah. Yeah. Now I can see you in both.
Right. I'll open the presentation on the laptop and speak over the phone.
Okay. You have joined, no? I can't see you. I can see you on the one device.
You should be getting another request from other one.
Yeah, yeah. It was there, then again. Oh, yes. Okay.
Yeah. Okay.
Oh, again, just lost. And now I can see. Yes.
Okay, fine.
Go ahead. Yeah.
Right. Apologies. So let's just start. So the topic we're going to talk about is wound bed preparation and how that's useful for healing. So let me just remind, I'm sure this is talked about earlier, but we need to remember again that the wound healing has a pathology, and it happens in different phases. And there are at least 3 or 4 different phases we talk about. The first one is the hemostasis, and then there's an inflammatory phase, a granulation phase, and then where there's proliferation, and there's a wound contraction, and where the scar remodels itself. So there are different types of phases. What is important is that it's a continuous process, but also these phases overlap. So in each wound, for example, there'll be different parts of the wound that are in different phases. That is important because a chronic wound, for whatever reason, stops at a particular point. And that is important to figure out where it has stopped and what we should do to make the wound move from one phase to a different phase. So, for example, a wound like this will initially have a inflammatory phase. You can see the erythema, you can see some inflammation going on, and at some point it proliferates, it fills up, and certain parts will start closing in, and the wound is almost epithelializing. You can see new pink tissue coming through. Whereas in the same wound, there will be some parts just still granulating, and inflammatory. But at the end of all of this, hopefully it should come to a closure, and that is what we're trying to achieve. So the idea is to try and figure out how we can do this. So a wound like this, the aim and the idea is to get to a point like this where it has healed completely. And to do this, you need to make sure that you put all the important friendly factors. So all the important things have to be there. And any things that affect it in a bad way, in a negative way, those things should be removed. And it's really important that to do this, we look at the entire patient and not just concentrate on the wound. So when you see a patient with a wound, it's really important, especially a chronic wound, and they often have multiple comorbidities, diseases, medical problems, nutrition issues, pain issues, psychological issues, social issues. Unless you sort and address all of these factors, sometimes it's very difficult to heal the wound itself. Now, and I'm sure this has been talked about at some point, and there will be various components, people talking about different aspects of wound care, especially in a palliative sense, in any chronic form. But today's topic is to talk about the wound bed preparation. Now, the wound bed is basically the wound that you see together with the surrounding area. And that's the wound bed we talk about. So how does one prepare the wound bed in order to heal a wound? And there are some guidelines on this, and I'll just go and talk a little bit about some concepts in this guideline. Right. Now, first of all, if a patient has a chronic wound and you want to try and heal this wound, it's really important that you try and identify and treat the primary problem. Now, any wound that you see in your practice, in the ward or in the private practice, that wound will heal eventually, provided that the primary things have been addressed. At the same time, the opposite of it is that unless you treat these primary problems, whatever you put to the dressing, however expensive those dressings are, however much you spend time on a wound, however frequently you put the dressing, they probably won't heal unless you get these primary things sorted out. And this one we call the VIP of wound care. And the V stands for the vascularity, that's the blood supply. I stands for infection, and P stands for pressure. So it's really important that we look at these three things and make sure these three things are sorted out, unless otherwise the wound will not heal. So when you say vascular supply, it is arterial, making sure the good blood supply is there. Sometimes it could be the poor drainage, that will be like a venous problem. Infection is the presence of infected tissue, infective soft tissue, sometimes bone like osteomyelitis. Those things can be there. And pressure is talking about foot deformities where there is imbalance of pressure. We'll talk about this in time. So the first task that I would think about when you're doing a wound bed preparation is to make sure that these are intact and sorted out. Now, unfortunately, a wound does not come saying, no, this is my problem. My problem is this. So it's really important that we, as the clinicians involved in seeing the patient, in the outpatient or inpatient, that we spend some time trying to look for this. And we can use all our senses, looking at the wound, talking to the patient and listening to his problem. We can feel the wound and notice various things. Sometimes the odor, the smell of the wound will tell you a lot of things. So they're practical things, but I'm sure most of you all are involved in wound care, have a general idea of how to do this. But I'll tell a few things about some important aspects. So if you look at arterial assessment, I think the most important thing here is to think about palpating the pulse. The pulses have to be felt, because sometimes the wound might look good, might not look good. There'll be black tissue, all these things will be there. But it's really important you think about checking for pulses. And if you check for these pulses, you can get some idea as to what's going on. There are various other features that you can look for, but these might not be always reliable. Certain measurements can be done, but these are often not available in a hospital setting or outpatient setting, and even in Colombo, these things are not always available. Of course, if you look at the wound and the wound looks, black, there's black tissue. This is what we call necrotic tissue. and sometimes there is not necessarily black, but blackish looking pale tissue with a discoloration happening through, then you would almost always feel that there is some problem of the blood supply. So in these instances, it's really important that the pulses are felt. But remember, sometimes even on a wound, in any wound, these are not always very easy to find. So in practice, try and always feel for normal pulses. But at least if you do that, you might be able to appreciate an abnormal pulse. Now, venous is another aspect of the blood supply. So this we'll talk about some point. I've seen a lot of people have these big tortuous varicose veins, and then it happens because the valves in those veins are not working. Right? And you can see patients with classic features of the venous ulceration or venous ulcers, in the classic sites, for example, the lower leg, around the ankle, on the inner side or the outer side. There'll be discoloration, pigmentation, black looking colors. You can see varicose veins, sometimes you might see swelling. So all these things will point you towards a problem of the venous system. Sometimes the lymphatics also look like it, a different pathology, but you can it's probably okay to put them in one group because the management tends to be rather similar. So apart from this problem, the next one we talked about was the P, the deformity. Now, deformity unfortunately means that the foot has lost its shape, and when that happens, the pressure of the body as the patient walks are not in the right normal places. They go into abnormal places. And when that happens, you find ulcers happening on those pressure points. So it's very important that these things are looked at and looked for in order to make sure the wound can heal. Because unless this is sorted out, then you cannot heal the wound. So if you suspect ischemia, the blood supply is not good, needs to be sent to a vascular person who can look into sorting the blood supply out. The problem is venous, then the surgeons are able to control and sort the varicose veins or the venous compression. In lymphedema, there's compression, and in neuropathy, it's about offloading the pressure and trying to manage the deformity. So this is the first thing to do, to make sure if you see a patient with a chronic wound, that you spend enough time trying to identify and then treat the cause. Now, once it is done, and you think the patient can have a wound that heals, then it's really important that you think about the local wound care. And this is the point where the wound bed comes to place. Right. So the wound bed, we talk about a certain concept. There are different types of concept, but one common classic one is called the time concept. And if you can remember this, you will remember what to look for. So it's an acronym. It means the T stands for what's called the tissue, I for infection, M for moisture, and E for the wound edge. So when you look at a wound, idea is to look at these four things at least will help you decide as to what you should do to make the wound better. But these things come only if you make sure that you sort those primary things out. Right. So what's the next step? The tissue. And in general, we talk about 4 different types of tissues. And if you look at the colors, it will help you to figure out what these might be. Black would be necrotic tissue. Yellow would be slough. And it's not pus, not infected. This is a wound sort of exudate that comes through called slough. Red would be nice granulating tissue. And pink tissue is normally this epithelial tissue. The wound edge is coming closer. So it's a continuous process, but the idea is trying to move from the black or the yellow to get to a nice red color. And if you get a good red color, you're probably able to end up with a nice pink epithelial tissue. So to do that, you need to sometimes we use various techniques. Apologies. So if there is tissue that is not healthy, for example, black tissue or necrotic tissue, then the tissue needs to be removed for the wound to be better. Otherwise, it can get infected. It affects wound healing. So you want to make sure that the bad tissues are removed and the wound is converted into a nice, healthy, clean wound. So there are various methods of doing this, and surgery is one of them. So if you're working in a surgical ward as a nurse and you see these various wounds, you might see surgeons taking them to theatre and doctors cleaning the wound. It's a very fast way, but it also requires a lot of experience going to theatre, cost, pain, all those things. But especially when there's an infection to sort out, or there's a very lot of bad necrotic tissue, then of course this is a useful method. Some other pictures you can see a lot of necrotic tissue, but there's also infection, and you might wonder that this looks like it's a ischemic wound, but once the wound is cleaned nicely, it's a lot of good tissue that you can see from underneath. So the wound has been converted from a black, yellow, ugly wound to a nice red tissue. Same here, another diabetic patient with infection as well as black colored tissue and cleaned up for a nice healthy wound. This is surgical debridement to make sure the tissue is appropriately placed. And if you look at this version, even though there's a small hole or a neuropathic ulcer, what you can see is also pointing of a wound infection happening. Really important that all the unhealthy tissue are removed and the wound is made into a nice, clean wound. There are other methods that can help to clean the wound. They're not always available. But also remember, the patient doesn't need to go to theatre all the time for a cleanup. Sometimes you can use the wound dressing itself to clean the wound. Dr. Thusitha Kahaduwa will talk about various wound dressings and how this can be done. A very classic example is using something simple like saline. And that wound on the left, which looks very yellow and murky, with time, if you use an agent that can help to dissolve that slub, can be turned into a nice red tissue. Sometimes you use maggots, use enzymes, and use various dressings that can be used to try and clean the wound. So the first task was to make sure the tissue is healthy. And the healthy tissue is really important for a healthy wound. Now, eye is about infection. And it's very difficult to talk a lot about this, but I'm sure you see infection and pus and all the bad stuff in the wound. The patient might be unwell, and you know the classic features of inflammation. Sometimes the wound's red, there's pain, it's swollen. All these things are there. But remember, any wound where that is exposed to environment will have some bugs. So they're all contaminated. And low amounts of bacteria are actually okay and they're required. We cannot have a sterile wound. The problem is when there are lots of bugs and that shifts the balance and it can invade locally as well as it can enter into the bloodstream and cause sepsis and septicemia. So the idea is to, as much as you saw the tissue out, is to remove or reduce the amount of bad infected tissue. And this can be done with antibiotics sometimes. It can be systemic or topical. Of course, be very careful because these can cause resistance. We often use antimicrobial dressings, and that is sometimes helpful to try and clean the wound from a local agent. Sometimes it requires surgery, like the pictures I showed you earlier, where infected tissue have to be removed. So it's really important you first be able to identify this. That's the primary task. So how do you identify it? There are various criteria, and I've listed out some for you all to read upon. Excuse me. But if you see a wound that is not healing, the exudate is smelly, purulent, there's discharge that doesn't look good, looks like pus, the smell is not good, the exudate color is not good, then you know something is going on. There might be inflammatory features, redness, warmth, swelling. You know, there's a possibility of wound infection. Of course, if a patient has a lot more significant features like fever, loss of appetite, tachycardia, then a systemic infection is placed. We often want to think about how to collect samples because we like to take wound swabs to know exactly what bug we're trying to aim at. So when often we ask when do we think about taking a sample like a wound swab, tissue sample, and it's all clinical judgment because we, like I told earlier, as since all wounds are contaminated, if you do a swab, you'll always get a bug. What is important is to try and make sure you take a swab or a tissue sample at the right time. Between samples, it's often better to take a clean tissue sample rather than a wound swab. Not always easy in a ward, but it will be the better sample to take if possible. So, about that. So we have done the tissue component, done the infected component. So next task is to make sure that we'll have the nice moisture. So how to make them sure the wound has an optimum moisture is the next thing you want to do. Because even if you have a good quality tissue and there's no infection, unless the wound has an optimum moisture, the wound cannot heal. So it's like a patient, just like us, on a very hot, dry day, you don't feel good, you feel very dry and tired. At the same time, if it's too moist, like patient with heart failure, flu, bloated, again, it's not good. And you see these wounds that are exudate, a lot of discharge coming through. The dressings won't stay for even a day. Weeping, lot of seepage. So even that is not good. So idea is to maintain optimum moist wound. And that helps to reduce the formation of scab. It allows the wounds to epithelialize faster. It also helps some form of occlusive debridement. It preserves growth factors. It reduces pain and makes life easy for the patient. So in general, it is very important the moisture level is controlled. How do we do this? And mainly it's about the dressings and the dressing frequency. You don't always need to have sophisticated dressings. I mean, you do find lots of dressings that are there in the market, and Dr. Kahaduwa will talk about this, that will help to maintain the moisture. Sometimes it's using very simple things like saline, using it more frequently, or making sure the patient's advised as to how to change their dressings if they're at home, or elevation, for example, and make sure the right amount of moisture is there. And you know that the moisture is too much when the wound gets macerated. The peri-wound skin is white, the skin around the wound is edematous, wrinkled. There's too much of moisture. If the wound has no moisture at all, it looks very dry, then you got to make sure you try and use a mechanism of putting moisture in. Right. So this is not something we often get involved in, the epithelium edge. And these are stuff that's very expensive as well. But it's really important that you pay attention to make sure the wound is closing. And if you see pink color tissue coming from surroundings, from the margin, and the wound is getting smaller, that's what we want. Sometimes, rarely, you find wounds that have a good tissue quality, not infected, good moisture, but the wound doesn't close. And these are kind of wounds that will need some help. It could be seen like a skin graft, various expensive dressings, they're available, but don't worry too much. If you get the first three sorted out, I beg your pardon, this will automatically happen. So I won't spend too much more time, but just to remind again what we talked about, it's very important. The first thing we should do is to try and look for a primary cause. Make sure the VIPs are looked at, assessed, and treated. Once that's the case, it's about the local wound care. And that's what the time concept talks about. Making sure the tissues of good quality, infection is being sorted out, adequate moisture is there, and the age effect will work itself out. Also remember that the patient and the family needs to be looked at and joined in, because unless the patient and the family are happy to go on this long journey, because this takes time. Then the outcome might not be what you want. So last slide, and remind that it's about making sure all these factors are important, and it's a holistic wound care if you want to heal the wound. Thank you. Back to you, Professor Madhi and Dr. Thusitha.
Thank you, Dr. Thushan. Thank you so much. I think can you spend 2-3 minutes and explain in in brief in Sinhalese, because I saw some in chat box. If you can only explain in bilingual, please.
Yeah, sure. Sorry, I didn't see the chat box.
Yes.
Let me just use this. Mama may pituwe koka kiyanna.
Yes, please, Thushan.
අපි දැන් මේ විනාඩිය චුට්ටක so තුවාලයක් සනීප වෙන්නේ නැත්නම් අපි අර උඩු දුවන තුවාල කියලා කියනවා. මේ තුවාල සනීප වෙන්නේ නැත්නම් මොකක් හරි හේතුවකින්ද ප්‍රථම දේ තමයි අපි මුලින් බලන එක ඒ තුවාලට හේතුවක් තියෙනවද කියලා බලන එක. ඒ තුවාල සනීප නොවන ප්‍රධාන හේතුවක් තියෙනවද කියලා. ඒ ප්‍රධාන හේතුව සනීප කරන්නේ නැතුව අපිට තුවාල ඉස්සරහට සනීප කරන් යන්න බෑ. මෙතන අපි කතා කරන මූලික හේතු සාමාන්‍යයෙන් අපි තුනක් කතා කරනවා. එක තමයි රුධිර සැපයීම. ඒක ඇවිල්ලා දමනි මගින් ලේ එන එක. විශේෂයෙන්ම තුවාලට ලේ එන්නේ නැත්තම් අපි කියනවා අර ඉස්කීමික් තුවාල. ඒ තුවාල ලේ නැත්තම් ඒ තුවාල සනීප වෙන්නේ නැහැ. ඒත් එක්කම තුවාල වලින් ලේ ටික පිළිවෙලට පිටත් කරගන්න බැරි නම් විශේෂයෙන්ම නහරවල නැත්තම් රුධිර ශිරාවල ප්‍රශ්නයක් තිබ්බොත් මොකක්ද අපි කියනවා අර වැරිකෝස් නහර ඒ වගේ දේවල් තිබ්බොත් ඒ තුවාල සනීපන හොරයි. ඒකට එක දෙයක් තමයි රුධිර වාහිනිය ගැන සම්බන්ධතාව බලන එක. දෙවෙනි එක තමයි පැසවීම නැත්නම් ආසාදනය. ඒ ආසාදනය පොඩ්ඩක් පරීක්ෂා කරලා බලන්න ඕන කොහේරි පැසවීමක් තියෙනවද කියලා. සැරව වගේ දෙයක් නැත්නම් ආසාදනය වෙච්ච පටක ආසාදනය වෙච්ච අස්ථි කොටස් අපි කියන ඔස්ටියෝමයිලිටිස් කියලා ඒවා තිබ්බොත් ඒවා අයින් කරන්න ඕන. එතකොට අපි ඒ දේ බලන්න ඕන. තුන්වෙනි කාරණය තමයි අපි අර VIP කියලා කිව්වේ P නැත්නම් P වලින් අපි කියන්නේ පීඩනය ගැන. පීඩනය. ඒ කියන්නේ කකුලක හැඩයක් නැත්නම් සාමාන්‍ය පරිදි එක් තැන්වල තියෙන පීඩනය වෙනස්. ඒතකොට ඒ තැන්වල තුවාලන්න පුළුවන්. අපි ඩයබටික් කටේ ගල් තැලුම් කියලා කියනවා. ඒ වගේ ගල් තැලුම් වගේ දේවල් එන්නේ විශේෂයෙන්ම අස්ථි උඩ නැත්නම් යටිපතුල් තැන් වල එන්නේ. ඒ පීඩනය එක හා සමානව පැතිරෙන්නේ නැතිඳ කකුලේ ඇවිදිනකොට. ඉතින් ඒ වගේ කට්ටියට අවශ්‍ය දේවල් ටික මුලින් කරලා ඉන්න ඕන. sorry. රුධිර වාහිනිය ප්‍රශ්නයක් නම් ඒ කොල්ලේ හදලා දෙන්න ඕන. නැත්නම් වැරිකෝස් නහර සනීප කරන්න ඕන. පැසවීමක් ආසාදයක් තියෙනවා නම් ඒ ආසාදනය අයින් කරන්න ඕන. නැත්නම් ඇන්ටිබයොටික් දෙන්න ඕන. පීඩන සම්බන්ධ ප්‍රශ්නයක් නම් ඒ පීඩන ඉවත් කරන්න ඕන. ඒක ඩ්‍රෙසින් එකකින් හරි එම්ත සපත්තුවෙන් හරි ඒ දේ කරන්න ඕන. ඒ දේ කරන්නේ නැතුව ඉදිරියට යන්න බෑ. දැන් ඔය ටික සකස් කරපු තුවාලයක් නම් ඊළඟ වැදගත් දේ තමයි තුවාලේ සම්බන්ධයෙන් තුවාල කොටස කොහොමද බෙහෙත් දාලා පරීක්ෂා කරලා බලන්න කියලා. එතනින් අපි කතා කරා කොටස් කීපයක් මම පොඩ්ඩක් අපස්සට යන්න. මේ ටයිම් කියලා එකක්. එතන දේවල් හතරක් ඔළුවේ තියන. ඒ හතරෙන් තුනක් ඇති ඔළුවේ මතක තියාගත්තොත් එතන කියන්න තියෙන්නේ T කියන්නේ පටක ගැන. අපිට අවශ්‍යයි කළු පාට දේවල් නෙමෙයි, කහ පාට දේවල් නෙමෙයි. හොඳ රතු පාට පටක. රතු පාටින් පටක තිබ්බොත් ඒකේ හිමින් රෝස පාටලා වැහෙනවා. එතකොට අපි කතා කරා කළු පාට දේවල් තිබ්බොත් කොහොමද ඉවත් කරන්න කියලා. ඒතර ශල්‍ය කර්මයක් වගේ වෙන්න පුළුවන්. අපි ටිකකට ගිහිල්ලා සුද්ධ කරලා ඒ කොටස් අයින් කරලා දැම්මොත් තමයි රතු පාට පටකට තුවාලේ හරවන්න පුළුවන්. සමහරලාට ඒ නරක පටක ඔපරේෂන් කරන්න ඕනේ නැහැ. ඩ්‍රෙසින් එකකින්ම කරන්න පුළුවන්. එතකොට සේලෙන් ඩ්‍රෙසින් එකක් ඉන්න පුළුවන්. ඇසිඩ් ඇසිඩ් වගේ දේවල් දානවා. ඒ දාන ඩ්‍රෙසින් එකකින් සමහරට පුළුවන් පටකේ වෙනස් කරගන්න. වෙන જાති දේවල් තියෙනවා. ඒ ටික ડોક્ટર තුසිත පස්සේ මට එයා ඩ්‍රෙසින් කතා කරද්දි කියයි. එතකොට ඊළඟ අපි කතා කරේ මේ පැසවීම පාලනය කරන්න කොහොමද කියලා. ඒක හුඟක් වෙලාට ඇන්ටිබයොටික් වගේ දෙයක් වෙන්න පුළුවන්. සමහරට ශල්‍ය කර්මෙන් උනත් කරන්න ඉඩ තියෙයි. සමහරට අපි ඇන්ටිබයොටික් වගේ දේවල් නැත්නම් ඒ වගේ දේවල් බොන්න දෙන්නේ නැතුව තුවාලට දාන්න නැතුව අපිට වෙන ක්‍රම තියෙනවා ඒව සකස් කරගන්න. එතකොට ඩ්‍රෙසින් එකකින් කරන්න පුළුවන් සමහරලාට ඒ වගේ දෙයක්. වැදගත් දේ තමයි අපි අර නිකම් දැන් කොහොමද දන්නේ මොන විසබිද්දද කියලා චෙක් කරන එකට නිකම්ම වූන් සොබ්ස් වගේ දේවල් කරන්න හොඳ නැහැ. අපි තීරණය කරන්න ඕන පේෂන්ට් බලලා තුවාලය බලලා අපි මෙයාකින් සාම්පල් එක ගන්නවද කියලා. ඒ වගේ සාම්පල් එකක් අරගෙන අපිට සකස් කරලා බලන්න පුළුවන් මොකද්ද හොඳ ඇන්ටිබයොටික් එක දෙනවා නම්. ඒ දෙන නොදෙන එක තීරණය කරන්න හුඟක් වෙලාට ක්ලිනිකල් ජජ්මන්ට් එකක් ඇතුව. වූන් සොබ් එකට වඩා පටක කැල්ලක් ගන්න පුළුවන් නම් තුවාල සුද්ධ කරලා එයා වඩා හොඳයි. තුන්වෙනි දේ තමයි තුවාල තෙතමනය. අපි වගේ තමයි අපිට ප්‍රශ්න තනන් ඉන්න බෑ. හුඟක් වතුර වැඩනම් එතන ඉන්නත් බෑ. තුවාලෙත් ඒ වගේ. තුවාල සනීප කරන්න ඕන නම් තුවාලට අත්‍යවශ්‍ය ප්‍රමාණයක වතුර ප්‍රමාණය තියෙන්න ඕනේ. හුඟක් තෙත වෙන්නත් බෑ. හුඟක් වේලෙන්නත් බෑ. ඉතින් ඒ දේ බලන්න පුළුවන් අපිට තුවාල දැක්කහම තුවාල හුඟක් වීලී වගේ නම් ඒ තුවාලට වතුර ප්‍රමාණය තුවාලට වැටෙන්න ඕන. ඒක ඩ්‍රෙසිං එකකින් කරන්නත් පුළුවන්. ඒක කරන විදිහ අපි පස්සේ කතා කරලා බලමු. තුවාල හුඟක් තෙතමනේ වැඩනම් ඩ්‍රෙසින්ග්ස් තියාගන්න බෑ. ඩ්‍රෙසින්ග්ස් ඔක්කොම තෙමෙනවා. සමහර කට්ටිය කකුලේ බේරි වතුර එනවා. ඒ වගේ තුවාලේ වතුර ප්‍රමාණය අයින් කරන්න ඕන. ඒ කරන ක්‍රමය අපිට කල්පනා කරලා බලන්න පුළුවන්. ඩ්‍රෙසින්ග් එකකින් කරනවද? බෑන්ඩේජ් එකකින් කරනවද? කකුල උඩ තියන් කරනවද? ඒ එක් නොඑක් ක්‍රම වලින් මොකක් හරි ක්‍රමයකට අපි තුවාලට අත්‍යවශ්‍ය ප්‍රමාණය වතුර ප්‍රමාණය තියාගන්න ඕනේ. ඒතකොට අපි අන්තිමට කතා කරේ ওই ටික ඔක්කොම එකතු කරලා අපිට තුවාල සනීප කරන්න ඕන නම් මෙන්න මේ ස්ලයිඩ් එක මතක තිබොත් ඇති. වැදගත්ම දේ තමයි අර දකුණු පස තියෙන අත්‍යවශ්‍ය දේ සාධක ටික සකසා ගන්න එක. ලේ සැපයුම, ආසාදනය සහ පීඩනය. අනිත් පැත්තට තුවාලය ගැන බැලුවාම තුවාලේ අපිට අත්‍යවශ්‍ය පටක ප්‍රමාණය තියෙන්න ඕන. හොඳ රතු පාට පටක තිබ්බොත් හොඳයි. ආසාදනයක් කොහොමද අඳුරගන්නේ? තිබ්බොත් මොකද කරන්නේ? ඒ ගැන පොඩි අවධානයක් තියෙන්න ඕනේ. සහ තෙතමනය ගැන අවධානයක් තියෙන්නත් ඕන. වැඩි තෙතමනක් තියෙනත් හොඳ නැහැ. අඩුවෙන් තියෙනත් හොඳ නැහැ. ඉතින් මෙන්න මේ කාරණා ටික පොඩ්ඩක් අපි තුවාලයක් දැක්කොත් දකින්න ඕන තුවාලෙක පොඩ්ඩක් සලකා බැලුවොත් අපිට අදහසක් ගන්න පුළුවන් අපි ඒ සම්බන්ධයෙන් මොකද කරන්න කියලා. අපි මේක ගැන අවධානය යොමු කරන්නේ නැත්තම් අපිට ඒකන වෙනසක් කරන්න ආයි හිතෙන්නෙත් නැහැ. අපි දාන ඩ්‍රෙසින් එක මොකද්ද? කොච්චර සැලකින් මාරු කරනවද? නිතර මාරු කරනවද? දවස් 3න් මාරු කරනවද? මේ වගේ එකක් දානවද? බැන්ඩේජ් කරනවද? බැන්ඩේජ් කරන්න එපාද? මේක අපිට මැනේජ් කරන්න පුළුවන්ද? නැත්තම් ඒ සම්බන්ධයෙන් වෙන කවුරු ගාට අපි පේෂන්ට් යොමු කරන්න ඕනද? ඔය කරුණු කාරණා අපිට හිතන්න පුළුවන් අපි මේ කරුණු ගැන අවධානය යොමු කරොත් පමණයි. So ඒක තමයි මට ඔය ගැන කියන්න තිබ්බේ.
Wonderful. Thank you so much. I love your Sinhala explanation. Thank you so much, Thushan. So thank you so much for taking your valuable time during the heavy casualties, as you mentioned. So thank you so much, Thushan. I hope you will join next session also. You have a talk, and I'm looking forward to hear the symposium in our annual academic sessions. So you will be participating, no? Today we spoke to Mandika sir, so he agreed to come.
Excellent.
Yes. So he agreed to come. So you just have a chat with him, okay? And please attend to my book launch also on the 16th, huh?
Will do. I'll be there.
Yes.
Sure.
Please. Okay. Thank you so much. Thank you, Thushan.
No problem.
We didn't give any time for questions though.
Yeah, sure.
Anyway, fantastic lecture, Thushan. Yeah, just
Yes.
converted into Sinhala. That was great.
So that is really nice. That is right. Okay, Thusitha, you can carry on. Yeah, please.
Okay. Any questions on this? Anybody has any questions? Apparently not. So okay. Shall I start then?
Please. Now Thushan has to move his slide sharing. Then
Yeah, he has to
only you can-
end slide share.
Okay, now you can. Yes, Thusitha.
Yeah. Hope everybody can see the slides.
Yes, yes.
So this is a kind of a fun lecture. So I want some involvement. Is everybody awake and there? I mean, are you with us? Can you give us any sign of life out there? Hello.
Yes, sir. Yes.
Yes, sir, we are
Okay,
here.
okay. There is life out there. Good. So now today I'm going to talk about how to select the ideal dressing. So that's the basic thing that you all came to learn, isn't it? So this is going to be very interesting. So what I am trying to do is I'm not going to go into very theoretical stuff. I'm trying to introduce a system of thought, a thought process to choose a dressing, simply choose a dressing. So just follow me on this, and I need some involvement as well. So you okay, not the most clear picture, but Thushan just spoke about this. This should always be on your mind, when you are seeing a wound. So this whole process of wound healing, this is what we are going to support. We are not doing this, the body does it, and it has evolved for million years to do it, and this is what we are going to support. So who started wound dressings? The oldest known description of wound dressings were from 2200 BC, that is before Christ. කියන්නේ ජේසුස් වහන්සේ පහළ වෙන්නත් අවුරුදු 2200කට ඉස්සෙල්ලා තිබිච්ච ක්ලේ ටැබ්ලට් එකක තමයි ලියලා තියෙන්නේ. ඉස්සෙල්ලාම සඳහනක් තියෙන්නේ තුවාල වලට බේත් දැමිල්ලක් ගැන. So what they have said was they have discussed 3 healing gestures: washing the wounds, making plasters, and bandaging. So this has been there for a long time. People knew that wounds has to be close to heal. So why close? ඇයි වහන්න ඕන තුවාල? මට උත්තර දෙන්න පුළුවන්ද?
To prevent contamination.
Yeah. So anything else? Simply, what does your skin do?
Protection.
Protection and කාවරි හැම ගහලා එල්ලලා තිබ්බොත් එහෙම මොකද වෙන්නේ? හැම ගහලා මේ තිබ්බොත් එහෙම.
Fluid evaporation.
Fluid.
Right.
Yeah, fluid will escape. And basically, what is skin? It's a huge immune organ, no?
Yes.
There's a deficiency in that. So there's a hole in it. In the sense, you have a hole in your innate immune system. ප්‍රතිශක්තිය නැති වෙලා එතන ප්‍රතිශක්ති කරන පද්ධතිය හිලක්. So that's why we have to close it. So when you are doing a dressing, you should have this idea. The primary dressing and secondary dressing and tertiary dressing, there are layers of dressings. You don't just you just put a dressing, that's what you do, but when you are putting it, you should know that what touches the wound bed is the primary dressing. There are certain things that we can do with it, and there are certain things that you can do with the secondary dressing as well, like protect in the primary dressing, give some compression and all that. And there are tertiary dressings also we can use to offload and all. Is that clear?
Yes.
Okay. So what is now we are trying to get the ideal dressing, no? So what is an ideal dressing? So the description of an ideal dressing is high moisture vapor permeability, non-adherent to the wound bed, high capacity for absorption, obviously, provide a barrier to external contaminants, as you all said, prevent capillary loop penetration into dressing material. And then you have bleeding when you remove the material. And capable of being sterilized. Otherwise, if you are trying to, when you are trying to sterilize it, it becomes a jelly. So you can't use it. Good addition to surrounding skin, hypoallergenic, comfortable to wear, cost effective. So that's an ideal dressing. Okay. So is there anything that is not clear because it's in English or whatever reason for it's not clear, and if anybody thinks that this should not be there in the list of the ideal dressing. මොකක්ද ප්‍රශ්නයක් තියෙනවද මේ ටිකේ මොන හරි ප්‍රශ්න තියෙනවද මෙතන තේරිච්ච නැති දෙයක් තියෙනවද මේක හොඳින් තේරුම් ගන්න ඕනේ but ඉස්සරහට යනකොට තව ටිකක් ඩිස්කස් කරනවා පැහැදිලිද
Yes, sir.
ඔව් වුඩ් බෙඩ් එකට ඇලෙන්නේ නැති වෙන්න ඕනේ උරා ගන්න පුළුවන් තරම් උරා ගන්න පුළුවන් වෙන්න ඕනේ එතකොට එලියෙන් කන්ටැමිනේෂන් විස බීජ වයින් දෙන්නේ නැති වෙන්න ඕනේ අලුතෙන් මස් වැදලියේ ඩ්‍රෙසින් එක ඇතුළට වැවෙන්න දෙන්නේ නැති වෙන්න ඕනේ නැත්තම් ගලවන්න ලේ යනවා එතකොට ස්ටෙරිලයිස් කරන්න පුළුවන් වෙන්න ඕනේ සාමාන්‍ය අපි ගාව තියෙන ඉක්විප්මන්ට් වලින් ඊළඟට good addition to surrounding skin එකට ඇලෙන්න ඕනේ හොඳට නැත්නම් ඒක නිකන් ගැලවිලා යනවා allergenic නොවෙන්න ඕනේ allergy ඇති නොකරන්න ඕනේ comfortable to wear කියලා කියන්නේ ඒක acceptance වල කැලලකුත් තියෙනවා හොඳ ඩ්‍රෙසින් එකක්. ඒ කියන්නේ අපි හිතමු තුවාලය සුද්ධ කරන්න ඕන ඩ්‍රෙසින් එකක්. ඒක වැඩි මිනිස්සු ඒකට කැමති නැහැ පිළිගන්න කැමති නැති. ඒකට උදාහරණයක් කියන්න පුළුවන්ද ටිකක් වැඩ කරලා තියෙනවා නම් වුන්ස් එක. ප්‍රශ්න තේරුණාද?
Sir, this is regarding the importance of dressing, no, sir? It's regarding that one?
What?
Is regarding importance of dressing. These are the facts. These are the importance, no?
No. These are the factors.
Yeah.
This is how you define an ideal dressing. An ideal dressing for a wound.
Okay.
So this is the definition of an ideal dressing. These things should be there.
Okay.
That's what the book says. So did you get my question? Can you give an example to a wound that is not comfortable, a wound dressing that is not comfortable to wear? Oh, patient doesn't like to have it on their body.
Burn wound, sir?
What?
Burn wound?
No, I'm not talking about wound. I want a dressing that is uncomfortable or
Okay.
unacceptable. In the Sri Lankan setting, no, just what I wanted was say the maggots, they come in packets, or even if they are in packets. So otherwise, people don't like to wear have maggots on their body. No?
Yes.
However much they support wound healing, people don't like to have maggots.
So some patient complain about disturbance of their body image due to dressing.
Disturbance of their body image, yeah, that's true. That's a very true concern. You have to be very conscious about their body image. I mean, they probably not every day in our setting, but say if they are going to a wedding or a social gathering or something, You have to be you have to put it in a such a way that their body image is protected and their dignity is protected. There are ways and means to do it. So this is an ideal dressing. So is this list absolute? I mean, for any wound, this the list, or is it relative? තේරුණාද ප්‍රශ්න තේරෙනවද? මේ ලිස්ට් එකමද හැම තුවාලටම තියෙන මේ ලිස්ට් එකද? මේකද අයිඩියල් ඩ්‍රෙසින් එක හැම තුවාලටම තියෙන? නැත්නම් තුවාලෙන් තුවාලට වෙනස් වෙනවද අයිඩියල් ඩ්‍රෙසින් එක? තේරුණාද? Hello, no life on earth. උත්තර
වෙනස් වෙන්නේ නැහැ නේද sir?
ආ?
This is the basic I think. වෙනස් වෙන්නේ නැහැ නේද?
No, this is just a theory, just it's not an absolute thing for every wound. හැම එකටම මේක නෙමෙයි. මේක තමයි මේ ලිස්ට් එක මෙහෙම ඒවා තියෙන්න පුළුවන්. මෙහෙම ඒවා තිබුණොත් තමයි ideal dressing එකක් කියලා කියන්නේ කියලා මෙහෙම විස්තර කරලා තියෙනවා. ඒ වුණාට තුවාලෙන් තුවාලේ තියෙන ප්‍රශ්න අනුව ඒ තුවාලෙට ideal dressing එක අපි තෝරගන්න ඕනේ. ඒක තමයි අපි ඉගෙන ගන්න යන්නේ. තේරුණාද? ඔය ඔක්කොම ටික තියෙන ඩ්‍රෙසින් එකක් තිබුණොත් මේක ගිහිලා මේකටම දැම්මට එහෙම හරියන්නේ නැහැ. සමහර ඒවාට ඒක පොඩ වැඩිපුර තියෙන්න ඕනේ ඇබ්සෝබන් ගතිය, සමහර ඒවාට මොයිස්චර් දෙන ගතියක් වැඩිපුර තියෙන්න ඕනේ. තුවාලෙන් තුවාලට තියෙන ප්‍රශ්න අනුව අයිඩියල් ඩ්‍රෙසින් එක වෙනස් වෙනවා. අයිඩියල් ඩ්‍රෙසින් එකේ තියෙන අයිඩියල් කම්පෝනන්ට්ස් ටික පොඩ්ඩක් එහා මෙහා වෙනවා. ওই ටිකෙන් තමයි යන්නේ. ওই ටික තමයි එහා මෙහා වෙන්නේ. සමහර ඒවා අඩුවෙන් සමහර ඒවා වැඩි. තේරුණාද?
Understood, sir. Understood.
Okay. So this is my approach to wound dressings. It's very simple. It's very, very simple. Just be with me, listen to this carefully, and if there are any questions, ask. It's very simple. Huh? So, dressing types. I propose there are these two dressing types. These are moisturizing dressings and absorbent dressings. There are special dressings and all that, it will come later. So, just initially moisturizing and absorbent. So, moisturizing dressings means they give water. Hydrogels, or any hydrogel like Metrogel, your expensive thing, Intrasite or whatever, they are like 99% water. They give water. So there are absorbent dressings like alginates, foam dressings. Then there are dressings that take in and give water, that like retain and give, like hydrocolloids. They are trying to sort of balance out and give the ideal situation. Like, so then there are just protective dressings. They don't absorb anything. They just protect, like silicone dressings. And there are special dressings. They come out of a lot of research. I mean, those things, other ones also came out of a lot of research, but these things may more into antimicrobial action, odor control, maybe so many things. They are sort of specific dressings. They're quite expensive. So this is this is an internet approach to, this is, I think it's from NHS, so some credible source, but this is what you, if you search, this is what you get. So see what they have said. Goes to heavy drainage, officer primary to secondary dressings, non-adherent ones, prevents sticking to wound, and also foam, moderate to heavy drainage, provides padding, that sort of thing. So when you are trying to practically choose a dressing, is this thing helpful? Can you choose a dressing reading this? It's quite difficult, isn't it? So that's why I propose this model. Now, this is the interesting part. So when you are presented with a wound, so just think about a wound. First step is just see whether it's infected or non-infected. So you all were taught this, know how to identify infection from whether it's infected or not infected. So let's say now just draw this picture in your mind, right? Wound, whether it's infected or non-infected. If it's infected, your management target will be to reduce the bacterial load, and there will be odor and all that has to be controlled. And there's a lot of discharge that also has to be accounted for. And of course, you have to do the wound bed preparation, the approach with the time concept, times I plus tissue and all that, surgical drainage or whatever you do. And to choose the dressing, of course, this is wounds infected. You have done what is necessary in the wound bed preparation, and this you come down to the dressing should be antimicrobial. Can be a silver dressing, can be slowly release iodine, or if it's depending on the situation, can be acetic acid as well. So when do you use acetic acid? If you are suspecting Pseudomonas. So depending on what infection you are suspecting, you go for the dressing. And if there are important structures to be preserved, you better go for a silver dressing. And if you need a little bit of chemical debridement and slough removal as well, you go for solid iodine sort of thing. Is that clear? This should be drawn in your mind like in separate pillars. This is one pillar, wounds infected. So this is how you decide on the dressing. Is that clear? Hello.
Clear, sir, clear.
Good. So
Clear, sir, clear.
some people are awake and alive. So what about non-infected wounds? Non-infected. So non-infected wounds, you have to see whether they have necrotic tissue or not. If there is necrotic tissue, whether they have good blood flow or poor blood flow. So a wound necrotic with poor blood flow. So basically what you should do, immediately refer for revascularization. What is your management target? Keep it dry and infection free till surgery. Is that clear? How do we do the wound bed? No debridement until blood supply is corrected. Don't touch it. The dressing will be the betadine, paint and dry dressings. That's all. And don't compress it. Just put a loose dressing, just a dry loose dressing. Don't put betadine into a sob and just keep it there. Paint betadine and let it dry, and then put a clean dry gauze and put a loose plaster. And immediately send to the vascular surgeon or the surgical department. Is that clear? This is very important. Don't cut, don't try to do wound care in these cases. And there are so many other things as well. As Thushan said, you should not be looking at you should be looking at the patient as a whole, not the hole in the patient. So there is pain, a lot of pain, and these people will be malnourished and all that. You have to, see various aspects and do whatever you can to resuscitate them for the surgery. So no trying of fancy wound care in these things. Just keep it dry, refer immediately. So wound necrotic with good blood flow. Wound with necrotic tissue with good blood flow. What is the management target? Getting rid of the necrotic tissue. So that can be done either with sharp debridement, or you just let it demarcate. Let the body do the stuff. So debridement can be, as I said, surgical or chemical or biological. So after that, what do we apply? Just some gel to get it granulated. Give some water. About 99% of wound care is moisture balance, and moisture balance. And if you want to demarcate, again keep it dry. Like what we did earlier, just keep it dry. However, you are sure about the blood flow. I mean, the patient cannot go for surgery. Suppose this is a palliative patient. Hari amaru ledek nang surgery කරන්න බැයි නම් අපි wound එක පුළුවන් තරම් dry තියාගත්තාම ඇඟෙන් ගලවලා දානවා ඊටු ටික නරක වෙච්ච ටික. So again, no fancy dressings here also. Is it clear? Any questions up to now? Okay. So a wound that is not infected. Then we talk about necrotic, what to do if the blood flow is poor, what to do if blood flow is good. So there are no necrosis. wound, non-infected, no necrosis. මැරිච්චේවා නෑ, මැරිච්ච කොටස් නෑ. මැරිච්ච කුණු වෙච්ච කොටස් නෑ. Then we have to see whether they are slough, whether they are granulating tissue, or whether the wound is epithelializing, whether it's granulating or epithelializing, or they are slough. So, non-necrotic wound, non-infected, non-necrotic wound with slough. Our target is to remove slough and promote granulation. So you apply the time concept, wound bed preparation. What do we do? Wound cleaning and slough removal. So it can be done surgically or chemically, or just providing good moisture. The dressing selection is, if it's dry, give some water, use a gel. If it's wet, get it absorbed, use some foam or alginate or something. Get the water out. Is that clear?
Yes, sir.
You are with me, no? I'm just building up things on top of each other. So, non-infected, non-necrotic wound, which is granulating. So, what is the management target? Protect the granulation tissue and promote epithelialization. How do we do the wound bed preparation? Just minimal wound cleaning with no corrosives. So you don't need betadine. Just mop it. අතුල්ලන්න එපා එහාට මෙහාට මොප් කරන්න උඩ තියලා ගන්න එක තමයි කරන්නේ. නැත්තම් එපිතලයිස් වෙලා තියෙන ටික ගැලවිලා යනවා. And you can keep the dressing for at least a week. තියන්න හොඳ වෙනවා. So the dressing selection, low adherent dressing. And use Vaseline gauze. Or if it's really granulated and trying to epithelize, use a silicone dressing. And keep for some time. No daily dressings, EOD dressings every third day. No. Is that clear?
Yes, sir.
So,
Yes, sir.
Yes, sir.
Non-infected, non-necrotic wound, which is epithelializing. Management target is protect and promote epithelial tissue and promote tissue maturation. And what do we do in the wound bed preparation? Basically, there are no wound bed. It's epithelializing is closing. You don't have to do much. Just minimal wound cleaning. Again, no corrosive. Just mop it. If there's anything, can use a hydrocolloid dressing. It absorbs and gives, trying to maintain the sort of an ideal moisture balance. Vaseline gauze also can be used, but sometimes Vaseline gauze gets adhered and it cannot contain as much moisture as necessary. But yeah, with some gels you can use it. So just a few cases. Are we clear? Up to now basically the dressing selection lecture is over. Is there any question? I have introduced a thinking process to you, how to think when you see a wound, on how to use the ideal dressing for that particular wound. Any questions up to now? ප්‍රශ්න තියෙනවද? දැන් තේරුණාද? මොන හරි මේ තේරිච්ච නැති දෙයක් තියෙනවද? මොකද මේක එක උඩ තමයි ඩෙවලොප් වුනේ. පැහැදිලිද?
Yes, sir.
Yes, sir.
Others? Yes.
Yes, sir. Yes, sir.
Okay. So some cases. So these are foot abscess. So what is the management target for this?
Abscess must be drained, sir.
Yes. Then how do you choose the dressing? What sort of a dressing? These are wound infected.
Antimicrobial
Ab-
dressing.
Yeah, antimicrobial dressing. So which part of the dressing is antimicrobial? Primary, secondary, or tertiary? To remind, I have spoken about primary, secondary, and tertiary dressings. The primary dressing touches the wound bed. So which one should be antimicrobial?
So I think that primary.
Yeah, primary. So secondary, anything special in this secondary? You have drained, and it's a fresh wound. A little bit more goes, no? Then a tertiary dressing. I would do a tertiary dressing to offload this area. This probably was due to this actually was due to a callosity, infected callosity. So again, a pressure point. Get what I mean, no? So again, an infected wound. So you answered no. So a necrotic wound with poor blood flow. So what do you do to this? What's the dressing? උත්තර ඕනේ.
This patient referred to the vascular surgeon for the correction.
Yeah, but you
of
have to
the-
do a dressing, no? You cannot just send it like this. I mean, if somebody sees even in the road when the patient is transferred, they'll also get scared. What would you do? Betadine pain, dry dressing. Yeah. Would you do a crepe bandage?
No, sir.
No. Definitely no. So if this patient is a 98-year-old with Parkinson's disease and multiple comorbidities, he has had multiple strokes, is bedbound, and he will not he will not survive a surgery, even a tiny surgery. He will not survive. Well, then what would you do? Still the same thing, you have to refer, get an opinion, discuss, and then continue. But the dressing is dry. So there's dry gangrene. Patient comes with dry gangrene. Mismanaged toe wound, septic endarteritis of two vessels of the toe, and a pretty clear dry gangrene. And can feel the pulses. But anyway, I would advise anybody, if they are not capable of detecting pulses very confidently, just these kind of cases refer. If you miss it, you will that your miss will cost a limb. That is not a fair chance to take. Anyway, so this dry gangrene with good blood flow, either you can, if the patient can survive, you can do a clear sharp debridement, and then it's a sort of a moist new wound. So you can use antimicrobial dressings initially. Then when it's granulating, you can use some moisture retaining dressings, and then to protect the granulation layer and promote epithelialization, you can use some simple silicone dressing or a Vaseline gauze, and that sort of thing. Necrotic tissue. What would you do to this one? These are vital structures. Here's the hand. These are tendons. You can actually get this to heal with some function. Any idea? In these kind of cases, actually, it's safe to use some silver dressings initially. Then afterwards, actually, you can just use some Vaseline. That will also do once you got rid of the infection from the tendons. You have to use sterile technique always, and make sure that you don't put anything else. And a little bit of compression. Not too much though. Epithelializing wound. What would you use on this? Need some answers. Are you still awake?
Can apply resin gauze and hydrocolloid gel, hydrocolloid dressing.
Not both. It's either hydrocolloid or Vaseline gauze. But the thing is now this patient actually was a walking, ambulatory one. But the thing is, if this happens to a bedridden patient, how practical are those? That you have to think about it. I mean, your answer is correct. You have to protect the epithelialization. We just have to maintain moisture and not damage the epithelial layer that is coming up. Okay, again, demarcation. So I think that is clear. Just we have applied betadine and just kept doing dry dressings, and it's now demarcating. So the summary is we have to do dressings, but the ideal dressing for each wound differs from wound to wound with their inherent problems. So I have given you a framework to work on when you see a wound. So any questions? You can find similar sort of a presentation in my YouTube channel as well. And you can follow my Facebook page, the Dr. Thusitha Kahaduwa in that course as Wound Care Sri Lanka in Facebook. Just search Dr. Thusitha Kahaduwa, that professional Facebook page will come. Many things are discussed there, and I have shared some podiatry stuff as well. Any questions? So in the absence of questions, can we call it a day? Then thank you very much for listening and answering and all the feedback. And thank you very much for the College of Palliative Medicine for giving the opportunity to do this lecture as well. So over to you, Professor Samadhi. Can we call it a day?
Very good environment. I'm happy. So thank you so much, both Dr. Thushan and Dr. Thusitha Kahaduwa. I saw Dr. Kitsiri also here.
Yeah. Thank you very much,
Yeah.
Thushan and Thusitha. You've done a great job today.
Yes. Very interesting, no? Very interesting. I hope
I can get a feedback then. Dr. Kitsiri, what do you think about my just the framework? Simplified
Actually, very practical and very interesting. Actually, I also learned a lot. It's really nice. Yeah, thank you, Thusitha.
Okay, thank you very much.
That's wonderful, and I'm sure all the participants also learned a lot. And now we have only one day to go, but still I can see few they are putting in our common what you call the WhatsApp group. We can't join. Link is not working. I don't know what's wrong with them. But anyway, we had 27 participants. That's really good out of 36. Some they have excuse for today, but anyway, I'm going to put this as a recording on our WhatsApp group. Not the WhatsApp group, the YouTube. Then you all can listen, you all can go through again and again, and please do the assignment. Now, from the previous experience of the doctors' programs, out of 115, only 85 submitted. So without submitting this assignment, we are not going to provide any certificate, because then it's not worth. Okay. So again, I'm inviting all of you to join with our annual academic sessions. Still, there are some seats. If you are around Colombo, or if you are coming to Colombo on 23rd, that is after 2 weeks, Saturday, full day, you can join with our college annual academic sessions. You have to register to it, and there will be a full symposium about pressure ulcers and 3 plenaries. So that's good. So please think about that. So that is good. And on the 16th also at BMICH, I'm going to launch my book about the history of palliative medicine. So I invite everyone, if you all have time, you all can join. The 16th, that is next Saturday, 4 o'clock at BMICH Lotus Hall. You all are welcome as our colleagues, as our, and you can see you can participate for that. I hope Dr. Kitsiri also will join on 16th.
Yes, thank you for your invitation, actually. Thank you.
Because you are so into history now.
Yeah.
And actually, Kitsiri, once you did your one lecture at Kandy, you put a lot of historical things, and you mentioned about the history of the surgical history of palliative care.
Yeah,
so
exactly.
That is one of the turning point to me to write this, actually. So that's good. So your involvement also there. Okay. So
thank you.
Anyway, so then see you all. Once again, thank you so much and good night. Good night.
Good night to
all. Sorry,
Good
our
night, sir.
Janaki madam also here. Okay. Thank you, madam, for joining. Good night. Good night. Okay.